you can record it.
Oh, perfect. Okay, I'm recording it.
Okay, now I'm going to make you back the host, Doctor.
Okay, interesting. Yeah, you're right. My recording button has come up, but yeah, you're right. I did not have to agree. Interesting. I've definitely been in meetings I've jumped in where they said it's being recorded. Okay, all right, everybody on their best behavior now. So we'll try to keep it clean. Not that we weren't before. All right, so I'm not going to restart from the beginning. I'm going to keep going then.
That's good.
All right, so let's go from current slide. And okay, let's see. I can't see Zoom anymore, but can you guys see the slides now?
No, I think it's just click share screen.
Yeah, oh yeah, you're right. You're right. I just went into slideshow. I don't think I did the shared screen yet. Yep, good point. All right, let's do share screen again. PowerPoint. Okay, share that. Okay, great. And now I will play the show and hopefully I'll still be able to see my Zoom. Yeah. Okay, great. All right, we're back. Whew, okay, very nerve-wracking, right? Very nerve-wracking. Okay. Okay, so again, we're going to talk about surgical robotics, image-guided navigation, and integration. And then, Adam, we have that quiz, right? You asked me to prepare. That'll be worth double credit today, right?
Right.
We'll do the quiz. Okay. Yeah, no quiz. Okay, all right, so medical robotics. So what's going on? Anybody heard of the Da Vinci robot at all? You can raise your hand if you have, or, you know. So Da Vinci is a robot that came out, I don't know if it's 15 or 20 years ago now. So there's the robot there. And it was originally actually aimed at cardiac surgery. But it didn't take off there and ended up going, it'd be used in urology for prostatectomy, for something called nerve sparing prostatectomy. But the Da Vinci basically is a big console here. This is two parts. So there's a console where the surgeon sits here and controls the instrument. And then there's a robot arms that sit over the patient right here. And it's basically laparoscopic surgery, but it's robotically assisted laparoscopic surgery. So instead of the surgeon manipulating the laparoscopic instruments directly with their hand, by my two chopsticks here, the robot does it. And the surgeon sits at a console, and the robot also has a video camera that goes into your belly button so they can see inside. So in laparoscopic surgery, they put a camera through your belly button. They do something called insufflate. They pump in carbon dioxide and create a cavity that they can work in. And then they use their chopsticks from the side. But in this case, the chopsticks are being held by the robot. And you're sitting there at a nice display. You're very comfortable, very ergonomic. So Da Vinci has been successful. There has been some debate as to whether Da Vinci is better. But most prostate surgery is done that way, and it's a commercial success story. So again, the medical robotics, where for a while was very slow, and of course clinicians would be like, well, I don't need a robot, I trained all this time. Why do I need a robot? But we always say that the robot is to help the physician. So we're not replacing surgeons, just same thing. We can talk later on about the role of AI, artificial intelligence in medicine and machine learning. We're not going to take over what they're going to do, but we're going to help them, and so I think the forward-thinking surgeons, and certainly the younger surgeons, are all for this type of thing. If you've ever seen laparoscopic surgery, it's not very ergonomic. They're hunched over all day and very tiring, and one reason that surgeons can't do it past a certain age is that physically it's very demanding. But if you sit at this robot right here, you're sitting down comfortably all day, and I swear the one surgeon would come into the OR and almost slip his shoes off, and sit at the console right here and do that. So it's kind of neat. There are other companies. So the big one is Intuitive Surgical with Da Vinci. Some people don't like that company. They say they squash the competition. They do patent battles. But the truth is Intuitive is publicly traded and has done well. And if Intuitive had crashed and not taken off, I don't think there'd be any market at all now for medical robotics, because investors would say it's not financially viable. So the fact that Intuitive has done well, the only thing I don't like is they keep taking my good postdocs to work there, because they pay a lot more, in industry than we do in academics. So anyway, but Intuitive is the big leader in Da Vinci. There are other companies. If you look on the web, there's been an explosion recently in ideas for medical robotics. Hansen Medical is something for snaking catheters through the system. So again, if we want to talk about minimally invasive surgery or procedures, rather than cut you open, we can take catheters and snake them through your blood vessels and do things. That's usually done by someone called an interventional radiologist. There's a robot for spine assist. When kids have scoliosis, curvature of the spine, you literally have to go in and open the spine in this to me, very gruesome procedure where they put rods in to straighten your spine and screws into something called the pedicles, the back of the spine. And they do it by hand, but this is a little robot, Maser robot, that kind of rides along the spine and helps you orient the screws and make sure your placement is good. And then finally, a company called Mako Surgery for knee and hip, now acquired by Boston Scientific. When you do a knee replacement, it's very critical, the cutting plane, how you cut so that the knee implant fits perfectly. And if you cut well and get that knee perfectly aligned, you'll have good biomechanics and it will last for a long time. If you get it a little bit off, studies have shown your biomechanics won't be that good and you may, it may not last as long. You may have to come back for a replacement. You can imagine that a robot could help guide that cut much better than a physician could do freehand. So there's the idea of robots that will work, we call synergistically, with clinicians to do things. So the bottom line is we think there will be a robot, maybe a surgical robot in your future. Hopefully you won't need surgery, but if you do, you will want the robot, but you will want a robot with a clinician with a lot of experience. You can certainly say if you ever have to go in for a procedure, the number one predictor usually still of good surgical outcomes is experience. Not that new doctors are not trained well and are, ready to do it, but we joke, don't go in the hospital in July when the new physicians come on surgeon service right there, let them get up to speed. We joke, don't go get blood draws in July for people who donate blood when the phlebotomists are learning how to stick people for the first time. So anyway, that's a little advice. Okay. So robots is kind of a neat field, and it's an area, my PhD was in robotics. As I mentioned, I did my postdoc in Japan in robotics, and I worked for NASA for a while in robotics before I got into medical. So medical robotics is kind of my thing. Okay, here's some pictures of things. Okay, these aren't too gory. There won't be videos, right here. You'll be able to still eat your dinner. Okay, it's not like we used to, as we say, to get body parts. Then I didn't usually eat right after that. And the formaldehyde smells pretty bad too. But anyway, I digress. So this is a RoboDoc. This is one of the first robots, and this was for knee replacement with the idea of carving this cavity that a robot could help. But this was an early system, and this required a pretty wide exposure. That's not a minimally invasive procedure you're looking at right there. So RoboDoc did not really take off. But then if you look at the literature, and you won't be able to see this slide, it's just too small. But you'll see in the research area, here we have the area, eye surgery, neurosurgery, GI, with the pill cam, you stick down, and takes pictures of your intestine, cardiac, everywhere. There's been a lot of places that robots have been tried, but robots are not really the standard of care anywhere but the Da Vinci robot that we mentioned with urology. So we think there's still a lot of room for robots. I was actually on a call with NIH just before I got on a call with you guys, and what they want now is they want a robot for autopsies. So again, not to be too gruesome, but you guys are interested in perhaps a medical career. So in the area, the days of COVID, nobody wants to go in and do the autopsy, right? If you had a COVID patient, would you be the one volunteering to go in and get the tissue? So they would love a system where the robot could be teleoperated to get tissue samples for patients. And, they want to do that right away, while the cadaver is still fresh. And so that's a potential huge area for me is robotic autopsy. So categories of medical robotics. We probably don't need to talk about this too much for this group. This is more for the engineering, but usually robots work in what we call the term master slave. I kind of joke this is probably not politically correct in today's era right here. This is historical. But the idea is like Da Vinci, the Da Vinci robot is only doing what you tell it to do. You have two master arms you're controlling that control. The Da Vinci does not work on its own. And I think that's why they were successful. They did not change the basic paradigm of laparoscopic surgery, but rather they augmented it, made it more comfortable, more precise. For the surgeon. Okay, cooperative, we just talked about Mako robotics. That's a robot that could hold you and you guide you along a cutting plane right here too. And then pre-programmed, robot does the task autonomously. Not a lot of this because, are you going to trust the robot, versus a doctor? But there is one area where something called radiosurgery, this is used to treat cancer patients, and you use a very thin beam of radiation, and you want to make sure that radiation gets into the bad area, the diseased area, but doesn't hit the good area. And you can certainly imagine that a robot can direct that beam better than a person can. And obviously, you don't want to have another person in the room when you're doing radiation oncology. So robots have taken off in radiation oncology. And when I was at Georgetown 20 years ago, we put the first CyberKnife, which I thought was a cool name. Anyway, the first CyberKnife install in at Georgetown. So those are three categories. That will be on the quiz, okay? So when we ask what the three categories of robots are, you can go, ooh, 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 I know, right here, get your brownie points. All right, we talked about Da Vinci. This is just the operating room, looking at the arms. It's a huge sucker, mostly so it doesn't fall over, but holding these arms that are all draped. This is we call the attending surgeon, the one responsible. There's a resident behind him that you don't see sitting at the master console doing the case. The surgeon is watching here and watching the monitors. The good part about laparoscopic surgery, if you've ever observed, because they're watching a video monitor to see what they're doing, if you're in the room, you can watch the same monitor. They can describe to you what they're doing. You can see tons of videos on YouTube for any type of surgery. So that was one. When I was early at Children's, they were doing a procedure called Pyloplasty in kids. We don't do a lot of robotic surgery in kids because, as I mentioned, it was mostly for prostate. But Pyloplasty is the fixing the ureter when the ureter, which drains the kidney into the bladder, drains the urine, gets kinked. They have to go in and cut it out. And here they've cut it out and they're sewing it up. And they said the Da Vinci is a nice sewing machine because it can actually be easier to sew with the Da Vinci than traditional laparoscopic surgery. You can also marry imaging, such as intraoperative ultrasound. So laparoscopic video, when you do procedures, gives you a nice view of the surface anatomy. You know usually what's, quote, under the hood by your training. You know where you're going to cut. But if you want verification, you can stick a little ultrasound probe. They have a little drop-in ultrasound probe. And an ultrasound, for, again, people interested in medical imaging, is getting so cheap. They now have a $2,000 ultrasound that will hook up to your iPhone. It's a company called Butterfly Networks. We have a bunch of, so some people are saying, doctors in the future are going to walk around with both their stethoscope and their ultrasound device as well to check things out real quick. Ultrasound also, again, from the medical imaging standpoint, doesn't, of course, have any radiation, we'd say, like CT or fluoroscopy, so it's inherently safe. There's Makoplasty, we just talked about right there too as well, for knee and hip, and just has some, jigs, cutting jigs and things like that. The idea with all of these is you have some sort of imaging. You do something we call mathematically. If I've got an image of this phone and I'm going to operate, I need to know where I am. I take pictures, cross-sectional CT, and then I have to register my pen with those CT images, mathematically know the transformation from my pen to the phone screen so I can know where I'm going to press, if I was doing that autonomously. Human, you do that all visually in your mind. But with these, there's always a process, mathematical process we call registration. And then once you do that, the system can constrain the cutting planes. And you can imagine for the new resident on call, it would be great. You can't cut outside in a certain area. We say that the first motto of medicine is do no harm when you do things, okay? Okay, this is CyberKnife we talked about. A little hard to see from this picture. Patient lies on a couch. Radiation comes from this source. It's kind of moved to treat over the tumor, the area of interest, and typically multiple sessions are done. Okay, let's not talk about those today. Well, we'll talk a little bit about HIFU. So you can get some cool acronyms from your friends. Oops, sorry, a little too far. HIFU, high intensity focused ultrasound. So we just talked about ultrasound imaging getting better. This is not use of ultrasound to image, but ultrasound to treat. You probably remember as a kid, well, at least I did it, you could focus a magnifying glass on leaves and create a small fire, if you were a pyrotechnic or someone like that. And with HIFU, it's similar. You focus the ultrasound image on a point that you want to ablate or cook. So if you have bad tissue in the body, rather than cut it out, you take an ultrasound transducer and focus it and move it to each point, and you kill that tissue, and then it will go away and shrink, and you can monitor this HIFU with MRI imaging. So this is something we've been doing, and this is truly non-invasive surgery. So when we talk about the evolution of surgery, maybe we will go from maximally invasive, wide open, to minimally invasive, to non-invasive, to HIFU right here. Okay. All right. So that's a broad overview of robotics. We're going to just talk a little bit about MRI compatible robotics and why should you care. Anybody had comments on robotics? Anybody had Da Vinci surgery? You guys are probably way too young for that. Hopefully that didn't happen. Okay. Hopefully you won't have surgery in the future, but they'll have a robot. Okay. All right, let's go on to talk about MRI compatible robotics. And this is, again, getting a little specialized. But the big idea here is when I went to the kids, when I was at the adult hospital at Georgetown, everything, you had a big problem. You come in and they say, we're going to do a CAT scan, a CT scan, computed tomography. In CT, basically they put you in a scanner. Okay, it's got, we call a image source and a detector. It rotates around and they slide you through like this, and they get images of the body. And then they stack up the images, let's see, kind of this way, we call axial cross sections. They can do 3D reconstructions, but you can get very nice reproductions of your innards, and you can see, and a radiologist reads them and looks for abnormal stuff, so that's kind of CT. So, but CT does have some radiation. It's not huge. Some people say it's not that much more than you get on a cross-country airline flight. But, if you can avoid radiation, you try to avoid it. And in kids, we're particularly sensitive to radiation. So MRI is more expensive, more costly, requires more infrastructure to operate. You can't have a pacemaker or anything magnetic into you, in the MRI environment. But in Children's Hospital, we actually do more MRI than CT. So MRI is really our imaging workhorse, and MRI works a little differently. The physics of it are quite complicated, but in the bottom line, it produces axial images similar to CT, and it gives very nice images of soft tissue. CT is better for bone. So anyway, we don't use MRI too much for procedures, because if anybody's been in an MRI bore, it's pretty claustrophobic, right? The closed bore of an MRI. And it can also have this loud pinging, knocking sound, as it's switching its magnetic fields that some people find irritating. So we don't usually do procedures in MRI. We do some procedures, sticking a needle in, getting a biopsy under CT. But we want to actually now do procedures under MRI because we don't want to expose these kids to radiation. But a physician in a closed bore gantry can't really reach in. So we build little robots that sit on the body, and we build these on our rapid prototyping machines, and that can hold the needle. And then we will command these based on the images to orient the needle and drive the needle to the body. So that's a long rationale of why you want a body-mounted robot for needle positioning in a closed bore MRI scanner. So there's one of our early robots. There's me lying in the magnet with the robot on my shoulder. This is just a mock-up. We kind of say, don't do this at home right here. But the beauty is MRI is safe. There's no radiation. So there's no ethical concern, with me doing a mock-up like this, provided they don't operate the robot and drive it down into my shoulder. And apparently my lab people were happy with me that day because they did not do that. So that was MRI. Robotic notes, I think this is a little esoteric for today. Let's skip over that one. Okay, we'll talk a little bit more as we talked about the different types of surgery, going from open surgery to laparoscopic. Laparoscopic, typically a camera in your belly button, typically 2 instruments on the side to do things. I'm gonna have to move my camera down a little more so you can see my illustrations right here. But single port surgery is the idea. Maybe we could do it all through your belly button. What if the only opening we had to make was through your belly button, and we come down here and we, and then we branch off once we're inside, to do things. So this is a system that's being developed. Now, some people may say this is only cosmetic. Okay, sorry for the women in the audience, but say this is the women who want to wear their bikinis afterwards and don't want to have any, scars on their sides from their surgery. But some people say, no, it's got other advantages too. It's less infections. This has not really taken off because technologically it's very hard to do right here. But again, it goes to the idea of going from multi-port to single port. Again, later maybe to HIFU, non-invasive surgery. So that's kind of a neat idea. Okay, and then we just talked about HIFU. You know, so here was HIFU right here. You're treating with ultrasound. It turns out that MRI not only gives very good images, but MRI can also do temperature sensing in the body. So here this person has a lesion in the liver here they're trying to treat, and it's a little spot, and they're actually going to cook it with HIFU. So rather than open them up and take it out, they're going to cook it. Particularly good for elderly people, because elderly people sometimes do not do well under surgery and can have complications. So that's an up-and-coming treatment modality is HIFU. All right, we talked about Maser robotics in the spine. We won't talk about that too much. Okay, all right, here's the summary. So as I mentioned, I think it's still true. These slides are a little old, but medical robotics is evolving. Da Vinci has opened the door. A lot of work by researchers. Companies are selling products. You know, I think market will grow and there will be a robot in your future. Okay, so any questions or comments on robotics before we go to part 2 then?
Yeah, I do have a question actually, Doctor.
Yep.
The question is, you know, a lot of us do want to become physicians in the future, and you know, we're young, so we do want to get involved in medical robotics. How exactly can doctors like get involved in the in the actual process of making medical robotics? Yeah. Or is it just like the implementation of it?
Yeah. Well, I mean, you know, as you mentioned, you guys are still young in your career. I mean, for one, developing a new medical robotic is a huge undertaking. You know, they've always asked me, why don't you guys develop Da Vinci robot for kids? And I'm like, well, I don't have $100 million on me, you know, which is apparently what the company invested to, you know, to build their adult version. So it's usually best left to the companies, and the companies will have advisory board, but of course they'll want established clinicians, you know, who have been doing these procedures for many years. So for us, the best avenue still is, you know, to do interns. You know, we do have interns from time to time come through our labs. Obviously, we are not doing that now. We can't have any volunteers as well. Hopefully in the spring or summer, it'll open up, you know, and people who are interested can contact me. I always get oversubscribed because there's more people. But, you know, I think that's the best way. And then, you know, I think just what you're doing now, you know, organizations like this one, bringing in speakers and, you know, just being aware, you know, but it's, I don't have any short pathway to it. Okay. Okay, so what I think I will do is on image guidance, I will go a little more quickly, and then we'll talk about OR of the future, but it hopefully give you ideas on our technology developments effort. But let's talk about image guidance. So we talked about robotics, you know, in robotics again, both of these are systems to assist the physician. In robotics, the robot is holding it, you know, under control of the system or working synergistically with the physician. In image guidance, the physician is manually manipulating the instruments, but we are providing them background to do so, you know, so guidance to do so. So this is here, the definition is use of medical imaging. Tracking technology means how do we know the position of an object like this pen in space, and computer assistance. And of course, everything we do nowadays is computer-based. So this was kind of early on. So for a quote, an image-guided navigation, that's another term. The general idea is you have a point in the body you want to get to. So how are you going to get to that point in a minimally invasive way? Again, in the old way, when you could open up and wide open, you know, you would see the anatomy, you could see, but now you want to get to that point on the anatomy. Let's say I want to go into my shoulder joint. I want to make sure that my skin puncture point is leading me right to where I want to get on the inside, because I don't want to move it a lot, start tearing up things, and I don't want to puncture multiple times. So image guidance can help the physician do that right here by providing them assistance then. The early things, we talked a little bit about something called pedicle screw placement in the spine. So if you look at your spine, I think you guys all know you have vertebral bodies, right? What is it? Lumbar, thoracic, and cervical. Okay, another quiz question, so get ready right here too. But each you know, disc has a certain anatomy, and usually this big thing here, I think this is the spinous process. You can feel it going down your back right here. But when they put in screws, they want to go something called the pedicle, you know, which stays in the spine and doesn't take you into the middle where the spinal cord is. you can imagine that putting a screw through the spinal cord would be bad. And you want to avoid that, you know, right here. So the surgeons pretty much do it by feel. They tell me the pathway, but if we could give them image guidance to do it, they showed that they could actually improve the accuracy of screw placements and minimize complications. And this is commercially used nowadays in most cases, right here. We had done some work with open source early on. I'm a big fan of open source software too. I mean, I know companies have to have proprietary software to make money, but certainly for the academic community, open source is a good way to go. So researchers can leverage what other people do. There is a company called Kitware, a medical image company, that has actually made a business out of selling open source. So just like Linux made a business out of open source operating system, they sell open source medical image solutions, and they make their money customizing it and advising people on how to use it. So we use a lot of their software in the toolkits we build. When we track instruments, there are various ways. We track with something called optical tracking, where we put markers on our instruments and we can track them and we know their XYZ position in space. It doesn't work when you want to track inside the body. So now we have some electromagnetic tracking sensors that you can embed in your instruments, and you can actually track inside the body. We did some early work with this at Georgetown, where here's a patient here lying on their stomach. We're actually biopsying a lesion in the lung. These are all markers right here to, quote, register our system. We're going to track it, and we gave the surgeon a display where he could go down and guide his needle right to where he's going. In the lung, of course, the patient is breathing. So you have to ask the patient to hold their breath, and you try to go on a breath hold, but this was successful. The other work that's being done now is when you do ENT surgery, okay, right here, or you want to go down into the vocal cords, there are now ways of tracking your instruments so you can give physicians better viewpoint as to where they're going. Let's skip that one from Medtronic right here. Okay. All right. So image guided navigation. So again, this term here, relates to tracking instruments, overlaying on a model of the anatomy, and giving the physician assistance. And there are commercial systems now available in many areas. So next we're going to talk about the surgical cockpit. Oops, I have an advertisement. I guess this must have been when I was trying to sell my book in China. So if you want to read about this, some of the gory details, it's still available on Amazon. I think my colleague may have done an update. He asked me if I wanted to participate, but I said, no, I'm not writing books anymore. Okay. All right. So this is the surgical cockpit. So this to me is the operating room of the future. So again, for you guys who are interested either maybe in being physicians or in the medical career in some days, obviously it's going to be very technology heavy right here. We think surgeons will still cut. During the genetics revolution and things, the idea was always, oh, we're just going to have a pill for that, right? We're going to go in and alter your DNA or your genetic code and fix those things. And, certainly they've been able to do some things, but they've probably also found out that's more complicated than they thought initially. And so surgery is still a mainstay. Even the younger surgeons who are training now don't say, don't worry, I'm convinced we're still going to need to cut. Okay. So surgery will still have a place, but we want to do it in a minimally invasive manner. And I think the tolerance for reoperations is going to become less, right? Surgeons are going to be more and more scrutinized on their records. Hospitals will not be reimbursed potentially, if they have to go back in and reoperate or have a higher, number of reoperation rates than averages. So the idea is to bring all the clinically relevant information available to the surgeon at the point of care, and then let the surgeon act on that as a minimally invasive manner. So this was, again, some work. Anybody? Sprechen Sie Deutsch? Anybody? Where's Natalie, my language speaker? Sprechen Sie Deutsch? Nein?
Nein,
Bier?
ich spreche a little bit.
Yeah. There you go. So my German, most languages is limited. Things like ein Bier bitte, man fast draft, large draft beer. Yeah. So I know that in many languages, but otherwise.
A little bit.
Yeah, there you go. But anyway, this is a little bit in German, but about a new concept for the operating room of the future. And just kind of what I said, a lot of integration, a lot of computer technology, a lot of software right here. We had actually done some work with robotics and navigation for kidney procedures. If you actually have to get a kidney inspection, Okay, the way they come at it is a little bit painful. Okay, we won't say where, but they come from down here somewhere. Okay, and come up through your bladder, up through the ureter, into the kidney, and they look around. Well, that's probably much better than them opening you up and looking inside the kidney right here too as well. But they say to do a true kidney inspection, the kidney is like a bean, they say, and has a lot of calyces you have to go in. And it can be hard for someone operating a scope by hand to bend the scope back. So we suggested marrying the scope with a robotic system, which would guide it and giving tracking and inspection. So I think even in procedures such as endoscopy, you can imagine robotically assisted endoscopy. Siemens Zigo, this is more of imaging for the operating room. So you're starting to see more and more imaging in the operating room. So rather than just have pre-op images, do the surgery, sew up, let's go take a look and see how we did. We would like to confirm before we close. And so you have more and more imaging available within the operating room. All right, so here's, we talked about our big slides. I don't know if surgeons like this, but none of you are surgeons, so we can say, but this is coming from the left and circling around. Open surgery, again, you know, probably very, you know, complete, very good surgery, and touch everything, but, you know, huge healing times from all the scars you would take to get there. This is the early laparoscopic surgery. This is Da Vinci. Now the Da Vinci is holding the surgery instrument. Then we talked about single port, coming through one port. We didn't talk too much about notes, but this is surgery, natural orifice transluminal endoscopic surgery, coming through the mouth into the stomach and puncturing that way. So no external punctures, but internal. And then finally, you guys, probably not too popular a movie for your time, but there was a movie called Fantastic Voyage, where you could inject little things into your bloodstream and they would go around and do stuff. You know, to me, that's still a little futuristic. But again, becoming more minimally invasive, but more and more developing, dependent upon technology, you know, and to me, then also integrating the information. So we think the future of surgery is integrating surgical information with the ability to act on it in a minimally invasive manner. So all these things, you know, and they feed back. You got your patient data, your clinical workup, you know, your CTs, your labs, all those, your MRIs, your planning. Then you've got a plan, you've got to carry it out. You're giving intraoperative guidance and control. Then before you close and leave the OR, how did you do to avoid a re-op? So, you know, if we could provide kind of the surgical management system for doctors. So parts of this exist in the system nowadays, but nothing is integrated. We do have the electronic medical record. It's bringing together pieces of these, but I think this is still a pretty futuristic view right here. Okay, so again, the clinically data, and then all this data we could get, including all the genetics that we have right now too as well. You can imagine that a clinician cannot make sense of this without a computer, you know, and more based on statistics and probability. And of course, we talked about, you guys know all about technology, you know, that the fact that you can pack all this in the cell phone and I can travel around the world. I was in Austria a few years ago. And my daughter called me. I guess I still had my location turned on. And she said, "Oh, how is the Austrian Autobahn?" I'm like, "Woo, that's a little scary," right here too as well. So now I know to turn it off, at least sometimes right here. But, you know, just the fact that, so I don't think it's a shortage of technology. I think, again, it's appropriate use of technology. If you want a little light reading, this is probably still available on the web, or I can make it available to you. We did this back in 2004, called Operating Room of the Future, OR 2020. Some of these things have happened, you know, with robotics and things, some have not happened. I'm actually considering with one of my clinical colleagues, he now wants me to develop the idea for the remote exam of the future. So in the telemedicine aim, where we can't get our hands on the patient, what if we ship the patient a box with the sensors and monitors and pulse ox and a little computer and say, "Here, hook it up to me. Okay, jump on the video link. Move this over here. Let me look at your heart." You know, we sterilize everything, of course, in between. But, you know, are we going to have, he wants me to do a little workshop on remote exam of the future. So I'm considering that. So we could consider, Adam, at some point, if we want a project for your group, your team, you know, would try to define what could be in the remote exam of the future be of interest to the group.
It is. For our AMPC symposium, we would love to think about.
That might be very good. That project is actually being head by our head of genetics. And I kind of said, well, why would a head of genetics be telling me what the exam? He said, actually, our workups are among the most complete because we got to consider everything, you know, when we make our, so that might be a very nice project for this group.
That sounds perfect. Yeah, I'll be in communication with you about this.
Great. Great. This did not happen. Okay. This was supposed to be a computer-aided radiology surgery in Munich this year. Needless to say, that went virtual. So we're going to do it next year. We were going to do OR 2030 of that one. And then conclusions. Okay. So a couple conclusions. So again, medical robotics and image-guided navigation, which are areas I work in, will be part of the future. And the idea is to enable more precise surgery in a less invasive manner. I'm not so sure about the economics. You know, you certainly can imagine extending a surgeon's operating lifetime, though. Future is integrating these technologies, as we talked about, with all the digital information. Give the surgeon all the information. We still need the surgeon. We don't have the AI algorithm that's going to process all this to decide what's best for the patient. And so I think surgical teams need to create test beds, close cooperations with engineers, you know, and other professionals. And, you know, with the ultimate goal, you know, which is, I think, why you can feel good about this is provide better patient care. You know, so for us for kids, but obviously this could translate to adults. So let me stop there, and maybe we can take a few questions and have a little discussion.
Great. I've always been interested in you briefly mentioned the tech, what's it called, the nanotechnology. I wanted to hear a little bit of your perspective on how much further, like, what do you think the future of nanotechnology will be in medical procedures?
Yeah.
And how far are we away from like actually seeing any practical use?
Right. Well, I think for one thing, for another speaker you can recruit, there's the fellow, let's see if I can put it in the chat box right here. Okay. Oh, okay, there you go. There's some things in chat I can look at too, but let me put his name in here too. Let me close one or two of my other windows. There is a guy named Rohan Fernandez, who's now at GW. I think I spelled his name right.
I think I've contacted him actually before. Rohan.
Yeah, Fernandez. Let me see if I'll look him up to see. But anyway, he works in nanotechnology, and he was with our lab for a while.
Right.
And went to GW. So I think it's promising. You know, I think it's a piece, you know, of that big technological convergence I showed. But my guess is practical applications are still a little further off than we think. Right here, he's been doing nanotechnology for cancer treatments right here. And, you know, they're still at the animal stage. So my guess is, you know, I think, you know, I'm biased because I'm working in image-guided robotics. I can see applying those to patients in the near term. I'm not sure about nanotechnology. Cancer Center. Yeah.
Thank you.
He would be a good guy to have you speak. Fernandez, Nanomedicine and Immunoengineering Lab.
Great. I'll let him know that you recommended him.
Yep. Yeah. Tell him congratulations. I think he just got promoted. Something. Maybe it was. I think. Oh, he got tenure. That was a big deal. So
wow.
he did.
That's terrific.
Yeah. So should I look at the questions here, or were those?
If anyone has questions, they can just either speak up or put in.
Yeah. Why don't you guys? I'll look at Arun's right here. Was that for me, Arun, or is that to everybody in your group?
Oh, that's for everyone. That's in our group.
Okay, those are for your group. I'll let you guys, if you have questions for me, you can ask them live.
I think I do have a question. It might be a little bit silly. So my major is cognitive neuroscience. I am not doing anything related to biomedical engineering or robotics. How do you think I could get into that field later on?
Can you ask me that one more time again? It was Natalie, right?
Yeah, Natalie. Or Adam too.
Oh, okay, yeah.
Yeah, so you got your PhD in robotics, correct?
Yeah. Yeah, actually my PhD was in mechanical engineering, but it was in robotics area.
What did you study in your undergraduate?
Yeah. So I was a mechanical engineer all the way through. So I was at Duke. And if there's anybody a basketball fan, I'd say how long ago I was there when Coach K started. Okay. He is older than me, just for the record, you know, right here. But anyway, but for me, again, you know, it is kind of funny. I say I actually run kind of a biomedical group, and I actually never took biology. Even in high school, we didn't have to. So, you know, I kind of learned as I went, and I really was doing work for Department of Defense and for NASA before I got into medical like 25 years ago. So I would say from a career standpoint, you know, I would say first get the best training you can, because you can never go back and redo that. It will always, you know, be good for you. But, you know, I think you should count that your career is going to morph over time, you know, particularly for you guys, even more than us. You know, again, for my parents, maybe again, you could go work for IBM, you know, and you would work for IBM for life, you know, and that doesn't happen anymore, you know. So I think you have to be flexible. And then, you know, to me, of course, I would still always say, you know, do what you like right here. You know, if you don't like it, you know, even if somebody else tells you, well, it'll be a good career or whatever, it's just not worth it. But, you know, if you have a good background in the sciences, you know, you can morph to other things. I mean, if you're doing neuroscience now, I didn't show the slides on our ankle rehab work, but we've actually built an ankle rehab robot for kids with cerebral palsy that we use, and we have kids come through those trials. And one of the questions is how much neuroplasticity is in the brain. You know, if these kids have CP and these pathways are blocked because there was an injury to the brain, if you do 1 million repetitions, can you relearn those pathways? You know, and I think most, I'm not a neuroscience, but I think most research shows that there is potentially more neuroplasticity than we think. You know, so you can be involved. So again, you wouldn't have to be a biomedical engineer, but you probably, you know, if you got involved in a project like that, you'd have to be willing to learn a little bit about biomedical engineering while contributing, you know, your expertise in the neuroscience area.
All right, thank you.
Dr. Cleary, when it comes to artificial intelligence in the future of biomedical and with medical procedures, I know that you said that right now they don't really want to use pre-programmed surgical procedures and robots. How do you think AI is going to change that, and how long do you think it's going to be before we can see fully automated sections of surgeries? So like maybe like suturing or things like that.
Right. Yeah, I'll make that question a little broader too, just in AI in medicine and then surgery. You know, obviously that's also a very current, you know, area of great hype, and, you know, but one where maybe some of the hype is actually, you know, justified. You know, certainly the idea of AI, you know, in everyday life, maybe a little scary, you know, when your phone now asks you for autocomplete, you know, in your Gmail. And of course it knows your browsing history and where you've traveled if you let it. So it can suggest, you know, stores you may be interested in. But, you know, and, you know, of course now I have what, Alexa on one, and I have Google Voice on another, and Siri on another. You know, everybody's got what I would call speaker independent voice recognition that you don't have to train, which didn't exist to me even a couple years ago, and certainly not. So, you know, AI has had its successes. I think the main issue in medical is that I think medical actually has greater complexity, maybe than those other things even too as well, is that, you know, the individual variability in human body and how patients present, you know, and even again from genetic standpoint, you know, as you find more and more mutations and things like that. So, and then of course the whole legal issues around medicine too, as well. There has been work, you know, with a lot of stuff published on AI for this, AI for tumor board. Tumor board is, you know, when you have ill patients and they bring together all the specialists, how are we going to treat, you know, and where they've tried to run like Watson on tumor board. I think they tried it in Singapore. They said, hey, it's not quite there yet still. And, you know, let's say Watson comes up with the diagnosis, who's going to explain to the patient what the treatment plan is? It's going to be Watson or the physician saying, well, Watson tells me this. And the patient's going to say, well, what do you think? You know, so now on the other hand, in radiology, this is a very long-winded answer, but you know, in radiology, there's a lot of stuff now at radiology symposiums, because I've been in radiology a long time as well, you know, that we're always going to have this as a we call a secondary read, you know, so the chair of radiology say, yeah, radiology's AI is not going to replace us, but radiologists who are not familiar with AI or not willing to use tools provided by AI may become obsolete. You know, AI may do screening and may calculate volumes and say, hey, doctor, please confirm. You know, so then finally surgery, you know, which to me is even more risk adverse. So when are you going to be ready to say, oh, okay, here I've outlined where the tumor is, where you're on the table, I've registered you with my mathematical coordinate system, I'm going to have the robot cut that out now. You know, are you ready for, if you're the patient, you want to push the button for the robot to cut that out, or do you want me to cut it out? You know, you might say, well, Da Vinci's doing that. Well, Da Vinci's not doing that. Da Vinci's under the doctor. So, you know, I think the idea still that a robot is going to go in and do things is still a little ways away. You could think of it when you do bone, because bone is rigid and doesn't move. that a robot could sculpt out your hip, implant better. A robot, when you have soft tissue and things start to move around, and you'd have to re-image and do that. So it's a little beyond our technology. So again, when I talk to clinicians about robotics, I always say robotics and image guidance are here to help you and not to replace you. And, AI will fit in the same category. If you said, okay, look, I've got the statistical database worldwide of the thousands of these procedures that were done last year. And we found from analyzing that it actually works better if we remove a little more surgical margin. You lose a little more blood and healthy tissue, but recurrence rates are lower. And we've shown that statistically. You might say, oh, I'll change my algorithm to remove a little more. Could that be done? But, the problem with medicine is finding kind of equal cohorts to work on. Those 1,000 cases, are they all the same age, They certainly don't have the same genes. So lots of, to me, again, it's again, very long-winded answer, but still the art of medicine is in the enormous variability, even with very large data sets, makes it very hard for me to see that AI in the near term, will do anything on a primary basis. And even for the foreseeable future, it's going to be a secondary analysis or a factor to consider. But it will play a role. It will play a role. Yeah.
Mm-hmm. I'm sure that's the case. That makes sense.
Especially, so, you should learn about AI and know what it means and things like that. But I don't think you have to go off and learn like MATLAB for anybody who's in engineering and uses MATLAB. If you go to their homepage, they'll say, hey, read our AI toolkit. You can download our tools and you can play around with data sets. Yeah, great to play around and do that. You're probably not going to do that to predict your statistical chance of things or decide if, not that you should invest in the stock market or decide where to invest in the stock market still.
Right. And I'm sure like machine learning is also going to help with like AIs doing better surgical procedures. They can,
Yeah. We consider machine learning maybe to be a subset of AI in that sense. AI is kind of the broad popular term. Machine learning to me is a series of mathematical techniques to carry out those things. But it's very popular. Every conference you go to nowadays, I'll tell you, we'll have a session on AI and machine learning and how it's impacting that particular field.
Right.
Or I should say every conference you Zoom to nowadays.
Does anyone have any additional questions? I know that we've gone over like the hour threshold. I'm not sure if you're.
I have a few more minutes so we can take any more, but then we can wrap up.
Right. Anyone have any questions?
I guess I could think of something. I was just wondering while I was hearing the discussion, Dr. Cleary, do you think that AI and technology is going to become more critical aspect of med students and in medical school and such, even aspiring surgeons, or even what you were saying about how probably we could do telemedicine by just sending over like a package and things like that? And do you see in the future like any limits to how far we can use technology to aid us?
Yeah. Well, I think as I mentioned, I think they will play a role, and I think it's good for you to become conversant with those technologies. But to me, more so you can evaluate some of the hype around them, and be realistic. Again, I don't think they will replace, the hands-on training. Now, again, if the pandemic continues and students can't come in and lay their hands on patient, and simulation labs improve, you'll be more of that. So I think it's good to be aware. I wouldn't be concerned about them replacing, I still think the power of the human mind to assimilate data from multiple sources and to draw inferences, now it's great. We got the web. I can search everything I want and find things. And then I got to make a decision, on that information. And even if I had an AI assistant that recommended this course to me, I'd want to say, well, show me your line of reasoning, and again, like I mentioned, if you want to go into medicine, I think the human touch is still important. So when I go talk to the patient, I can outline that. So I think it's good to be aware. It may change some things about how you're training. The whole COVID pandemic may change, how training and teaching is done. But I still think, you know, having a good science base, knowing the fundamentals of a field, knowing how to reason from what I would call first principles, and, you know, knowing how to evaluate information, which I think to me is ultimately the purpose of education, is a critical skill. You know, I mean, again, even more, you know, for you know, young people nowadays, you know, all this information, how you make sense of it is really a critical skill. So I don't know if I answered your question, but those are my thoughts.
Thank you.
I just have one question. I think this is for everybody, but how can, as students like now, how can we get involved in biomedical research, whether that be at Children's Nationals or in DC? How can we begin the first steps?
Yeah, well, yeah, now is probably about the worst time. You think I can hate to say that too. I mean, but you know, from before, it was never really easy, because, you know, the key thing is you got to find some, you know, professor, someone who will take you as an intern or let you work in their lab and has enough, you know, we might call unskilled needs, you know, to make it worthwhile to do that. Again, even when my daughter was an undergrad in Vermont, you know, she got into a lab, but it took a little while. You know, and once she got in and was useful, of course, they were very glad to have her back and stay. But it's getting started. So, you know, I don't want to discourage anybody, but obviously now is not the time. I would say, though, if you guys are interested, whether a small group of you or under the umbrella of your organization, you know, of pursuing this idea of the remote clinic of the future, that I could discuss it with you. I do have one student from Yale who's working at home, who's just started looking at it for me today, but it's a pretty broad topic. And, you know, whether we could consider hosting a symposium on it again.
Right.
Again, I did this OR, which would be virtual, and whether, you know, we organize it under you guys and you guys do some of the legwork. I would be willing to explore that. I would have to then go back and run it with through the clinician, you know, who gave me the idea. But I think he is generally the more the merrier type of person. So that's something maybe you guys could discuss within your group. And again, the idea would be, if we wanted to find what the remote exam of the future is, with the idea is that we're going to develop a kit. You know, I'm joking, when I did my physical, do I still have it here? Yeah, I got my thermometer. I got my blood pressure kit for my physical this year, and I did it myself. You know, would we have a little portable ultrasound? Would we have a stethoscope? You know, and then would we, you know, make some sort of infrastructure software package? They hook it up. Everything's USB. You plug it in, say, welcome, put this on. The physician will be with you shortly, you know, and then they say, hey, what's this? And the physician has access to be able to see everything and instruct, as well as access to the readings from the instrument. You know, that's kind of my vision. So, you know, if it would be of interest to your group to kind of develop, you know, what that would look like, and, you know, a think tank type activity, that might be something we can propose.
I really like the idea. I think that AMPC is really geared towards that. We want to do that, especially with the AMPC symposium that we created. I'm going to be in contact with you after this meeting. We can discuss this.
Okay.
I know that a lot of our members are definitely involved and would want to be involved in this.
Sounds good. Yeah, that just happened to come up, so it may work out very well.
Sure. Terrific. Thank you so much for your time. We are so honored to have you.
Great. Well, it's good to see you guys. You guys are the future. So,
Thank you so much.
I'm glad that we are all here. And, you know, then you can follow up with me, Adam, all the Adams, Adam, Natalie, Adam, other Adams, things like that too as well. And, you know, then we'll see if we can do something from there.
Thank you so much, Doctor.
Okay. All right. Have a good evening, everybody.
Wonderful.
Yep.
Thank
Bye-bye.
you.
Thank you.
Thank you.
Thank